So now we're going to go to tibial shaft fractures. Right now, I know it's been a lot of information already. A lot of this is going to be said again, as there's a lot of overlap, obviously, between proximal and midshaft and distal third tibial shaft fractures. This most common long bone fracture, count 4% of all fractures seen in the Medicare population. And in terms of mechanisms, we just went over this with the proximal tibia fracture. Any fracture, low energy, high energy. Think low energy, result of sometimes torsional injury, indirect trauma, Scherney grade 0 or 1 for the soft tissue injury. So not really that bad, right? High energy fractures, direct forces. Okay, so sometimes a lot of comminution, a lot of muscle damage, a lot of periosteal stripping. And that's even if it's a closed fracture. Fibular fracture sometimes at the same level. Severe soft tissue injury, 2 or 3, sometimes an open fracture. So be on the lookout for that, especially high-speed MVAs. As you can see here, this is obviously an open fracture and a high-energy one, right? Comminution, periosteal stripping, lots of muscle damage. Okay, soft tissue injuries are going to be critical to the outcome. Think compartment syndrome. Just because it's an open fracture doesn't mean you're not going to have compartment syndrome. It doesn't mean the compartments were decompressed. Think about bone loss, ipsilateral skeletal injury. Is there knee injury, ankle injury? Extension, is there going to be an intra-articular injury, both proximally or distally, like such as a tibial plateau or posterior malfracture? Okay, so be thinking about that. Posterior malfracture, many times we'll see that with a spiral distal third. It will be the most common type, but always be on the lookout for other injuries, especially with these high energy fracture patterns. We're going to go through open fractures pretty quickly here, just a classification, but it's important to recall this. The Castillo-Anderson, type 1, limited periosteal stripping, wound less than 1 centimeter. Remember, even if the wound is less than 1 centimeter, it can be a type 3 injury because there can be a lot of soft tissue stripping on the inside. So remember that grading or typing of an open fracture is done at the time of debridement and not necessarily just on the image of the wound. Okay, that could be helpful, but it's not just done on that. Type 2 is going to have mild to moderate periosteal stripping, usually a larger wound, 1 to 10 centimeters in length. Type 3, significant soft tissue injury, okay? Segmental fracture, comminution, severe periosteal stripping, but there's going to be no flap required for a type 3A. Type 3B, though, requires many times a soft tissue flap or coverage. But the key thing to note here, a split thickness skin graft does not count as soft tissue coverage. Okay, this would still be that type 3A if you just had that. Type 3C has significant soft tissue injury as well as a vascular injury that requires repair. As one can see here, it's not really well illustrated in this image, but one can imagine if this would likely require some type of vascular repair to maintain limb viability. So symptoms, well, like any other fracture, pain, inability to bear weight, and a deformity, especially in the tibias. You can see it because it's a very subcutaneous bone, especially when compared to something like the femur. So inspection, palpation, look for deformity, angulation, rotation. Look for any issues with the skin, contusions, blisters, open wounds, compartments. Check compartments once again, whether it's proximal tibia, distal tibia, or tibial shaft. Palpate. Check if there's pain out of proportion, passive pain with passive motion of the toes, and if you're not sure clinically, check the pressures. Okay, make sure you know how to do this. But once again, if clinically it's compartment syndrome, the pressures do not need to be checked. Okay, neurological exam, just like when we did the proximal tibia fractures, it's the same type of exam. DPN, SPN, sural, tibial and saphenous nerve distribution, pulses. These are key, once again, especially for more high energy fractures. You want to check the dorsalis pedis, posterior tibial pulse as well. Check it to the contralateral side. If there's an issue, they may need an angiogram or further vascular studies. So next question. All right, so 35-year-old male patient sustains a twisting injury to his leg playing soccer. Radiographs are seen in figures A and B. You decide to treat this fracture with an intramedullary nailing. In order to prevent a misinjury that should be addressed during the same surgery, you order the following test. Okay, so misinjury, We're talking about a twisting injury. Okay, when you're talking about twisting injury, many times we're talking about a spiral third, and this will be also many times be someone slipped on ice, soccer. These are typical mechanisms you actually see in practice. So we talked about what's associated with a spiral distal third. Well, it's going to be the posterior mal. It's very hard to see on just many times on plain imaging. So, but you can get radiographs ipsilateral ankle. If you have sufficient radiographs, 3 views of the ankle, then a CT scan of the ankle is not necessary. It's been shown in multiple studies, but it's something always to consider with these fracture patterns. As you can see here, you want dedicated ankle views, if you can't get those, get a CT scan for a spiral distal third to exclude the posterior malleolus fracture. Many times these are more low energy fractures, torsional patterns. Once again, soccer players slipped on the ice and so forth, or hiking as well. All right, so next thing, imaging. We just talked about this before, but remember, you want to get full-length AP and lateral views of the affected tibia, the joint above and below. Make sure it doesn't go in the joint. If there's intra-articular involvement, think about a CT scan. If you can't see it well on plain x-rays, especially if it goes into the tibial plateau, or if you're not sure if there's a posterior malleolus fracture, as these are often associated. So question number 2 in this segment now for tibial shafts. Which of the following fracture patterns is classically associated with varus malunion if treated with closed reduction and casting, right? We just talked about valgus, apex anterior. We're talking about varus now. We really haven't gone over this, but so let's go over these figures a little bit more in detail. So figure A is going to be a excuse me, distal third tib-fib fracture. Okay, figure B is going to be a tibial shaft fracture. There's an intact fibula. Figure C is going to be a tib-fib fracture as well. There's quite a bit of deformities you can see here in displacement. Proximal third fracture for figure D. We know what the answer for that one is, so I think we know that's not going to be the answer to this question. And then figure E shows a segmental tibia fracture as well as a tibia fracture. So what's the answer here? Well, the answer is going to be figure B. Figure B showed a fracture of the tibial shaft with an intact fibula. So if you have an intact fibula, there's going to be an increase of malalignment during healing when treated closed. Okay, non-surgically treated tibial shaft fractures have a risk of varus malunion, and that's because the fibula acts as a strut. Okay, and that prevents valgus collapse, predisposing to varus angulation here. So that's kind of important to know especially when you're treating with closed reduction and casting for these fractures, which is a viable treatment option. So once again, treatment options, we went over this earlier with proximal third tibial fractures. Indications for closed reduction and cast immobilization include usually low energy fractures with acceptable alignment. That's going to be key, acceptable alignment. Less than 5 degrees varus valgus, 10 degrees in the AP plane, more than 50% cortical apposition, less than 1 centimeter in shortening. So those shorter oblique fractures that tend to shorten are not good for non-operative treatment many times, as they can lead to a limb length discrepancy. And many times if they're displaced, you can perform a closed reduction under general anesthesia, but oftentimes then you're just proceeding with fixation, unless there's certain patients who are not the best surgical candidates at the time and may need to be treated in a closed manner. So once again, technique, we went over this. Long leg casts convert to a functional brace at 4 weeks. Patients do not like this. I think I want to stress that. It can also lead to a lot of subtalar stiffness. That's one of the biggest complications for a non-operative treatment of a tibial shaft fracture, just because of prolonged immobilization, causing a lot of problems possibly later on. High rates of success if acceptable alignment is maintained. I think this is pretty much common sense. Risk of shortening with the oblique fracture patterns, we talked about that. It's very unstable. Risk of varus malunion with the intact fibula, right? The fibula acts as a strut. Low rates of non-union. We can treat these close, but many times we're going ahead and fixing many of these, especially for very active individuals. External fixation indications can be useful for proximal or distal metaphyseal fractures, especially using a fine wire fixator. Pin tract infections, just like with any external fixator, we're going to see those issues no matter where it's used around the body. higher incidence of malalignment compared to IM nailing. It's a lot of times used just as a temporary fixation and before definitive either nailing or plating, especially in polytrauma patients. IM nailing. So think about indications, as you can see here on the right, this image, a nail place for a midshaft tibia fracture. Indications: unacceptable alignment when you're trying to treat it close. Soft tissue injury where you can't put a cast on, right? You can't have circumferential cast where you can't analyze and observe the soft tissue. Segmental fractures, common fractures, all these are length unstable. Remember, length, alignment, rotation are always going to be key. Ipsilateral limb injuries such as a floating knee where you have a proximal femur fracture. Polytrauma, you want to get these patients up and moving, stabilize them with a nail, allow immediate weight bearing. Bilateral tibia fractures, could you imagine walking around with two casts on each leg? You're not going to be very mobile at all, cause a lot of issues. Morbid obesity, hard to really hold a fracture stabilized if you have excessive soft tissue. So I am nailing contraindications, pre-existing tibial shaft deformity. You got to pass the nail. If you can't pass the nail, you're probably not going to be able to nail it. You could perform an osteotomy, take out previous hardware, etc. Previous total knee or tibial plateau. A lot of times you can nail around these though, so it's not a strict indication. These just become, or strict contraindication. These just become a little bit more difficult. In terms of outcomes, IM nailing leads to decreased malalignment when compared to external fixation. You have a lot more control of the fracture fragment. Decreased time to union, decreased time to weight bearing. This is not always the case though because a lot of times if you're using a fine wire fixator, you can allow for immediate weight bearing. So next question, 28-year-old construction worker sustains the fracture closed injury shown in figure A and B after a fall from height. So we're thinking possibly high energy. You want to be looking for other injuries to the spine, calcaneus, etc. He's taken to the operating room. What is the next best step? So figures A and B show a distal third tibia and fibular fractures here, some combinations. So we're thinking higher energy. Think about maybe associates injury to the calcaneus or to the spine. So of the following answer choices, if we go over this, reamed IM nailing and fibular plating here is going to be the best. And I think sometimes this can be controversial, even though it's shown in some studies that fibular plating can allow for you to maintain or to obtain and maintain your reduction a little bit easier for these distal third shaft fractures. However, a lot of times these do not need, the fibula does not need to be fixed here, and so you know, this is kind of a little bit controversial based a lot of times on surgeon preference, but the plating of the fibula can definitely help you with rotation, length, and alignment for sure for these fracture patterns, which can be difficult. Of a distal third tibia fracture is going to be malrotation. So in terms of using a ream nail, allows for a larger, stiffer nail to be placed as well. So that's going to be the standard many times is going to be a IM nail, using a reamed IM nail for a closed fracture, as we're going to see later in one of the studies recently published. So once again, IM nailing, ream versus unreamed nails, and this is the study I mentioned, so the sprint. So reamed is possibly superior to unreamed nails for the treatment of closed tibia fractures. Decrease in future bone grafting or implant exchange. This was shown in the sprint trial. Recent studies show no adverse effects of reaming on infection and non-union, especially when you're dealing with a closed fracture pattern. So making that last question we looked at, helping us get the answer of ream nailing as well as fibular plating. So once again, ream versus unreamed nailing. Reaming with the use of a tourniquet is not associated with dermal necrosis. This is a theoretical risk, and the reason is because you don't have any venous outflow, increase in heat produced as well. I for one, do not recommend reaming with the tourniquet just due to the theoretical risks, but there's been multiple Cochrane reviews that have shown no difference between using a tourniquet and not a tourniquet. But once again, this has been a question in the past. Theoretical has never been shown clinically yet. So percutaneous lock plating, especially used for proximal tibial fractures, we went over that. distal tibia fractures as well, especially when you have, so you think about it, when you have short segment fixations proximally or distally, not really indicated too much in midshaft tibia fractures, except if it's possibly a PEDS, previous deformity, and so forth. Complications, non-union wound infection, dehiscence. Remember, these can be some bulky implants. Long plates also place the superficial peroneal nerve at risk when you place a percutaneous plate from proximally to distally, but also that can be injured as well when you're placing it like a distal anterior lateral plate as well along the distal tibia. So when compared to IM nailing, percutaneous plates have shown an equivalent time to union, greater radiation exposure. This is variable, right? It depends on the fracture pattern and surgeon experience and so forth. Longer surgical duration, also variable. Lower postoperative pain scores, variable, I would say. More difficulty in hardware removal. This just requires more extensive soft tissue dissection many times to take out a plate. But if you're not careful taking out a nail, you can do damage as well. But it's something to consider at least if you have to remove when you have to remove hardware. All right, so now we're going through this topic. I know we've covered a lot tonight already, but try to remain focused here. 25-year-old male pedestrian sustained a type 2 open tibia fracture after being struck by a car at 10 p.m. So we're thinking soft tissue stripping. He was transported to a level 1 trauma hospital where he was given intravenous antibiotics and tetanus at 10:45. Remember, IV antibiotics, tetanus, every open fracture. He underwent tetanus if they needed. He underwent irrigation debridement of the wound with 9 liters of normal saline and was treated with reamed IM nailing at 11:45. A vacuum-assisted dressing was placed over a 5.3 skin deficit. So that's a wound vac. What part of his overall treatment has shown to reduce the risk of infection the most at the site of injury? Remember, they're asking the most. So think about all these things that we want to get these patients fixed and covered early. In terms of being covered, we just see a skin deficit. So they're saying kind of like trying to lead you down the path that there's muscle over bone. And that's why you can just use a vac here. But one of the key things is it's going to be the answer for this question is going to be early intravenous antibiotic administration. This is going to be key, right? Next, probably be irrigation debridement with open fracture. But once again, antibiotics has always been shown to be the most important predictor of infection for these open fractures. Early intravenous antibiotics. Infection risk after a type 2 open fracture, 10 to 20%. This is high. All right, we got to get it lower. So remember, you want to get it done within the first hour, ideally, but within the first 3 hours for sure. You want to be thinking that usually you're going to be giving ANSEF for just a type 1 or type 2. Duration of antibiotic therapy, controversial. Usually it's at least minimum 24 hours. Some people do up to 72. There's no great consensus, but remember, the consensus is give antibiotics as quickly as possible. All right, so as we go forward here, once again, for operative treatment of open tibial shaft fractures, think emergent IND, or I like to think about emergent debridement irrigation. You want to debride the fracture and you want to do it systematically, skin, subcutaneous tissue, muscle, bone, and so forth, and then irrigate once you're doing that. Surgical debridement after 6 to 8 hours. Some people can say is preferred. Many sites have shown you can, once again, that the key is early antibiotics. So even waiting to the next day many times is very satisfactory. Grossly contaminated wounds are irrigated in the emergency department. Once again, you may want to be putting more broad spectrum antibiotics when thinking about more contaminated wounds. As we saw here, cephalosporins, so basically ANSEF, right? That's the orthopedic surgeon's best friend, as well as the ER's best friend for grade 1, 2, and 3. When we're thinking about higher grade or type fractures, remember you want to think about adding aminoglycoside. Many times this can be institution dependent and determined by the flora and the capabilities of your institution that you're at. For farm injuries, you want to think about adding penicillin as well. There's minimal data to support this, but we do this. Farm injuries also bump up your open fracture to immediately a type 3. Tetanus prophylaxis, make sure it's up to date. This is something that you don't want to miss. As we move forward here, external fixation is extremely helpful, especially with open tibia shaft fractures. Provides provisional soft tissue stabilization. You can see here a lot of the compartment syndrome looks like they were released. blistering and so forth. You can't fix this. You can't nail this. This is and you want to minimize any further soft tissue trauma that was already not done by the fracture pattern. It's also indicated in children with open physes as well. Have a tibial shaft fracture. That's not amenable to closed treatment. Excuse me. So IM nailing for treatment of open tibia fractures. Most open fractures can be treated with IM nailing within 24 hours. Contraindicated once again in children with open physes. Use flexible nail plates, external fixators, etc. Children and pediatric fractures are obviously a different animal. So when we think about IM nailing and outcomes for open fractures, IM nailing versus versus external fixation, no difference in terms of infection and union rate or time to union. IM nails, though, are better at keeping your fractures maintained, right? The fixation is closer to the bone, which would be stronger. Decrease secondary surgeries, because if you have less malalignment, many times you're going to need less future surgeries, shorter time to weight bearing, though with fine wire fixators and so forth and some other external fixator constructs you can weight bear as well. But nails are a much more a stable construct. Is there a load bearing implant? Or I mean, load sharing implant for a nail, allowing you to weight bear a lot faster. So next question. Okay, so a 33-year-old male presents with a comminuted open tibia fracture. So we're thinking high energy after involvement in a motor vehicle crash. Okay, we're thinking other injuries. We're thinking, okay, it's open. What do we need to do? We need to get antibiotics and tetanus. He has a history of smoking, but is otherwise healthy. Okay, we know smoking is bad for infections. He is given antibiotics taken immediately for irrigation debridement, followed by an unreamed stainless steel intermediary nail. Due to bone loss, there's a non-circumferential cortical defect measuring 12 millimeters. So basically, he has bone loss. There's a gap at the fracture site. That's what this is saying. This is a fancy way of saying that. All the following are factors in the patient's history and presentation to increase his risk for adverse outcome, except, okay, a lot of people will probably not like this type of question in terms of accept, but just think about what are the risk factors, okay, of non-union and issues, okay? So high energy and mechanism, right? That's going to be a risk factor. Implant material, fracture gap as well, because fracture gap is shown to be one of the leading issues in terms of going on to a non-union in a tibial shaft fracture, history of smoking as well. And why is number 2 the answer? Well, the use of an unreamed intermediate nail for an open tibial fracture has not been shown to increase the risk of adverse outcome or the need for reoperation. All the other answers have been shown. Okay. High energy mechanism, we talked about use of a stainless steel nail because the modulus of elasticity is different. That's why we use like titanium nails, carbon fiber nails as well now in some cases. Residual fracture gap greater than 1 centimeters, right? Bone loss, history of smoking. Smoking's bad, right? No one's ever said smoking's been good for us. And the use of reamed and unreamed nails, though, for open tibial fractures have been studied, and no significant difference has been found. Right? These are both. If you whether you ream this or did not ream this nail, it would be very acceptable treatment options for an open tibial shaft fracture. So IM nailing for open tibial shaft fractures. Outcomes for open fractures: IM nailing versus external fixation, ream versus unreamed nails. Once again, we just went over this question, but we're going to highlight this again because this has been tested now multiple times, okay? Reaming does not negatively affect union, infection, or need for additional surgeries in open tibial fractures. Gapping at the fracture site is going to be the greatest risk of non-union. So just always remember that greatest risk is going to be the gapping at the fracture site. So as we move forward here, we looked at a randomized trial of reamed and unreamed intermediate nailing of tibial shaft fractures by Bendari. Actually, not by, yeah, by Bendari and Tornetta here. And you can see that the investigated reamed and unreamed nailings for tibial shaft fractures in the SPRINT trial, okay, they concluded that reamed nailing was more beneficial for closed fractures, that's key, but had no benefit in open fractures. Okay, no detriment as well, but no benefit. Okay, so this is a key study that several questions now over the last several years have been based on, as we just went over one of them from the question bank. So next question: which of the following is an FDA-approved adjunctive treatment for acute open tibia fractures treated with an IM nail. Once again, I think most of us know what this material is. I think this is fallen more so out of favor, and many studies have been challenged, uh, especially more recently in the last several years. But Infuse or BMP2 is indicated or is FDA approved. I want to say indicated, FDA approved for the using while treating acute open tibia fractures with an IM. Now, it was shown in some studies that are now called into question to accelerate early fractured healing because it increased angiogenesis and so forth. But right now, once again, called into question. It's important to note this, but I think right now it's very controversial, and some of it may not be as well tested as we thought. The jury's still out, though. So once again, in this study, effects of human bone morphogenic protein, BMP2, in grade 3 open tibia fractures treated with unreamed nails, a clinical and health economic analysis. In this study, it was done more recently, they found significant decreases in need for secondary interventions such as bone grafting or nail exchange. Mean time to fracture healing was less in the BMP2 group, but this difference was not statistically significant. So, was it the BMP2? Was it something else? Some of these studies have been called into question. Well, once again, BMP2 has been shown to work. How effective, we don't necessarily know, but it is useful, and many times it is used off-label for many non-unions as well. So, in terms of operative treatment for the operative treatments for open tibia fractures, think about amputation indications. There's no current great scoring system to determine if an amputation should be performed. Okay, you can't just add all these numbers up. It's going to be multiple factors, very difficult decisions sometimes. Relative indications, though, significant soft tissue trauma, right? Especially if it's non-reconstructible, warm ischemia time, severe ipsilateral foot trauma if the foot's not reconstructible, and then the tibia is not. An amputation may often, unfortunately, be necessary. And in terms of the outcomes of amputations, if we look at the LEAP study, most important indicator of eventual amputation is the severity of ipsilateral extremity soft tissue injury. Kind of makes sense, right? Soft tissue injury is going to take hold. It's a relatively subcutaneous bone, the tibia. So if there's issues there, then we're going to possibly have issues with coverage, infection, non-union, malunion, etc. Most important predictor: transfer to definitive trauma center. Definitive trauma centers. Why is that the correct answer? Well, they have the usually most trauma centers will have a team dealing with limb preservation, and that requires a multidisciplinary team and a significant amount of resources. Study shows no significant difference in functional outcomes between amputation and salvage. Loss of plantar sensation. This used to be a indication for amputation. It is no longer, especially the LEAP study really showed this and highlighted this. So it's important to realize that even though they don't necessarily feel their foot right away, it doesn't mean to amputate it. So as we move forward here in terms of now we're going to go as we talked about amputations, we're going to now talk about the technique for IM nailing, and this will be for proximal, distal, as well as mid shaft. Anesthesia, many times general anesthesia, but now we're doing this a little bit more into regional. There's some concern over regional regarding compartment syndrome and missing it, and people go back and forth regarding this, but once again, you should always be concerned about neurovascular and compartment checks when dealing with proximal, distal, as mid-shaft tibia fractures. Position the patient supine, radiolucent table, right? Because we're going to be using fluoro. Bump the patient. This helps internally rotate just a little bit to help us get our starting point. You want to have full access to the foot and ankle. I also find it very helpful to use the contralateral, to prep in the contralateral leg and limb, especially if there's any issues that I think I might have with determining length, alignment, or rotation. Use the other side as a guide. I think that's going to be one of the most accurate measures, especially intraoperatively, that can help. Tourniquet. Once again, tourniquet's not always used, but if it's going to be placed, you can place it just prophylactically on the proximal thigh. I wouldn't inflate it, and I don't think it's usually necessary in tibia fractures. And it's also, it can be used with if there's a vascular injury though, until they get control and so forth. Deflate during reaming and nail insertion. Once again, weak data support this, but many times I would argue and suggest that a tourniquet is not needed during routine tibial plating or nailing. So as we go further here now, in terms of the approach, we talked to many of these approaches right now. Some of them may be better or worse for proximal fractures. There's a medial parapatellar, most common, can be to valgus malalignment. Remember, you're going to sometimes get a medial starting point because when you're putting that guide wire in, you have to push the patella out of the way, and this can be an issue. Lateral parapatellar can be helpful with proximal third tibia fractures, but requires a mobile patella as well. Other options also include patellar tendon splitting, give direct access to the point. If the joint guys can take 10 millimeters of patellar tendon for PTB autograft, for an ACL, I think we can split the fibers as long as we do it well, and I think we keep the peritoneum intact and protected, as well as the tendon fibers protected as well, and do a good repair. Semi-extended nail, we went through this multiple times, used for proximal and distal tibial shaft fractures now. Suprapatellar is a form of semi-extended nailing, transquadriceps tendon approach where you just incise directly proximal to the patella and go basically down a bone and pass a guide. Retropatellar, it can cause damage to the patellofemoral joint. Be very careful if it's not done correctly. And just because you do a semi-extended or suprapatellar nail doesn't mean you're going to get out of a malalignment issue. It needs to be done correctly, and it needs to be done well. In terms of the starting point, once again, medial parapatellar tendon approach with the knee hyperflex, or a split tendon approach. Incision from the inferior pole of the patella just above the tibial tubercle and straight in line with the tibia. If for a medial parapatellar, you're going to identify the medial edge of patellar tendon. Sometimes take off a little bit of the fat pad, and then use a starting guide wires placed in line with the medial aspect of the lateral tibial spine. We went over some of those diagrams earlier in the talk, and that's going to be on the AP radiograph. And then on the lateral view, it's just going to be just below or anterior the articular margin. Remember as well that this is where tibial rotation and extremity rotation really plays an effect. You want to basically have on the AP view, for the most part, your fibular head bisected by the tibia by about 50%. And just next time you're in the operating room, try externally internal rotating the tibia and look at the AP view, and you're going to see quite a bit of difference as you rotate even just a few degrees. So make sure you get the good imaging to get the great starting point for this. For the starting point, semi-extended lateral or medial parapatellar approach. And now this is where you can make it through the quad tendon. You can make it on the side of the quad tendon, medial or lateral. It doesn't really matter. You can, a lot of times what I like to do is see how mobile the patella is and go from there. Knees should be in about 5 to 30 degrees of flexion. Remember, if you're too extended, then you're not going to be able to get a posterior starting point, a posterior enough starting point. You may ream out anteriorly in the tibia, and then you're too flex. You're putting too much pressure, especially if you're doing a retropatellar approach, between the patella, your guide, and then the trochlea of the femur. A lot of times I like to do like a finger sweep to open the retinaculum and joint capsule of the synovium. A lot of people have adhesions as well when you're doing this. If you're doing this retropatellar, if you're not doing retropatellar but you're just doing a large open approach, you can excise some of the retropatellar fat pad to help you get your guide wire. And then starting point, once again, starting point's the same no matter what approach you use. Just take your time. Fracture reduction techniques, we've talked about all of these though. Spanning external fixator, also known as traveling traction, clamps, right? Femoral distractor, Chance pins, joysticks, small fragment plates and screws. We saw this in a couple of the questions as well as the diagrams. Intracortical screws as well, so basically blocking screws, polar blocking screws. Remember, these are common, especially when you have a metaphyseal diaphyseal mismatch, such as in the proximal and distal tibia fractures. So IM nails, reaming, ream nails superior to unream nails and closed fractures. Be sure tourniquet is released. Advanced reamers, over ream, it depends on your system by 1 and 1.5 millimeters. Confirm the guide wires are appropriately placed prior to reaming. Key thing there, right? You want to make sure that you reduce and the guide wire is in the right place before you ream to in order to prevent iatrogenic damage. Nail insertions, some people will say insert the nail slightly in external rotation, help you get those distal interlocking screws anteriorly, decreasing the risk of neurovascular injury. If the nail doesn't pass, check what's going on. Something might be wrong. Get a fluoro in there and reassess at that point in time. Don't try to just slam a nail in there. Locking screws statically lock proximally and distally for rotational stability. There's really no indication for dynamic locking. Number of interlocking screws is controversial. If you're having a more proximal or distal fracture, you're going to want at least 2 to 3 screws in each of those fragments with a short segment fixation. In terms of knee pain, almost everybody gets knee pain. Okay, occurs with patellar tendon splitting, paratendon approach, occurs with retropatellar or semi-extended nailing as well. Lateral radiograph, just don't leave the nail proud. This can be a cause of knee pain, and that's easily avoidable by looking at a lateral X-ray prior to finally locking your nail. So we're nearing the end here now. A 25-year-old male sustains a closed fracture shown in Figure A. If a tibial intermediate nail is placed with the starting point shown in arrows, what subsequent alignment will occur? Well, Figure A shows that you're placing both a medial start point as well as a fairly anterior start point as well, right tubercle, affecting the extensor mechanism. So what's going to happen for this proximal third tibial shaft fracture? We've talked about this already. This should be all review for everybody, but once again, we just want to get it again. Valgus apex anterior. I think we've really covered this multiple times. Remember, because you want to have you want to have a correct starting point on the lateral view, and if anything, a more lateral starting point, not more medial starting point, to avoid the malalignment of a proximal tibia fracture. So once again, complications for a proximal tibia fracture, malunion has a high incidence of valgus and procurvatum. Varus malunion leads to ipsilateral ankle pain and stiffness. In terms of the discussing the angular deformities defined by both the proximal and distal anatomic mechanical axis of each segment. All right, so you'll be drawing this, and a lot of times that's why for like a proximal third fracture, we're saying it goes into valgus because we're looking at the distal segment, and this has been tested before in different multiple ways, as you can see here. All right, nearing one of the last questions here. A 40-year-old man is thrown off a motorcycle, sustains an open type 3 fracture shown in Figure A. He's taken to the operating room for debridement and reamed IM nailing with a 10mm nail. He returns 10 months later with persistent pain at the fracture site with ambulation. Examination reveals healed wounds with no erythema, warmth, or tenderness, right? So they're saying there's really no purulence, there's really no signs of infection here, right? No cellulitis. ESR and C-reactive protein levels are with normal limits. Once again, those are non-specific inflammatory markers. They're normal though. Radiographs taken at the time are shown in Figure B. What is the next best treatment? So we see in Figures A and B, we can see that this is basically a non-union of the tibial shaft. There's some callus here, but see the fracture line is still quite evident. So what's going to be the best treatment at this time? What's going to be exchange IM nailing? Now, even though there's no signs of clinical infection, right? No erythema, warmth, or tenderness, labs are normal. You need to take cultures because in many non-unions, multiple studies have shown that there is a very high rate of actually being have an indolent infection. So that's going to be, you could do you can do an exchange nailing, but I would argue possibly doing a biopsy as well if that was one of the answer choices here. All these other answers are not going to be for this patient at this time. So once again, remember, reamed IM nailing is indicated. Lack of union 20 to 26 weeks post-injury, 9 months. That's going to be basically a delayed union, and 9 months post-injury, we start thinking about non-union, or if there's no progressive healing on 3 consecutive months when looking at the patient's x-rays. And always think about infection when you're looking at non-unions. Always think about infection. So once again, we just went over what delayed and non-union is. Treatment, nail dynamization, exchange nailing. Reamed is the most appropriate. Many times we go up by 1 or 2 sizes, especially if there's going to be no bone loss. If there's significant bone loss, high rates of this not working. Consider revision and plating, revision with plating and metastaseal non-unions, where you can get direct reduction and compression. But many times not necessary for an IM now. So once again, treatment of compression plating, especially for proximal distal tibia fractures, fibular osteotomy as well, can definitely help increase the time to union for these fractures as well. And this has been tested before. As we move forward here as well, so also posterolateral bone grafting, non-invasive techniques such as bone ultrasound, BMP7 or OP1, once again controversial, just like BMP2, but it's been shown in a couple of studies and been tested before as a effective adjunct for these non-unions. Malrotation most commonly after IM nailing of distal third fractures. This is where the fibula, fixing the fibula can help reduce risk once again with adjunctive fibular plating. We saw that earlier in tonight's lecture. Now in terms of compartment syndrome, it's one of the last topics and one of the most important. Incidence 1 to 9%. Occur in both closed and open. Always just be on the lookout for this. Okay, if you see it, if you think it's compartment syndrome, it most likely is. High index of clinical suspicion, pain out of proportion, pain with passive stretch, and if you're not sure clinically, make sure you get compartment pressures, and then that can lead you down the road of doing an emergent four compartment release, single or dual incision. That's based on your experience and preference. Compartment syndrome, don't miss it. Once again, most common reason for successful malpractice litigation. So big thing is just don't miss it. Prevention, increased compartment pressure found with traction and leg positioning at times as well. Always be on the lookout for it. And then nerve injury as well. List plate, we talked about this with plating tibia fractures, especially with longer plates. Expose the plate distally. Also, saphenous nerve can also be at risk immediately around the ankle. Transient nerve palsy can be seen after closed nailing. It's not compartment syndrome, but it can have some of the similar symptoms, and many times these patients present to your clinic, and thankfully many times the recovery does come back.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.